Hi everybody, today I'm going to talk to you about imaging in anterior shoulder instability. Before I go any further, what I want to say to all the resident doctors out there is that this talk is dedicated to you. I hope you can learn while you're doing all the wonderful work that you do out there for all of us and in keeping our city and our country safe and looking after all those who have been affected by the current COVID crisis. So the first thing that we need to understand is what are the principles of anterior instability. As you may be aware, there's a glenoid and a humeral head, and in an anterior instability event there is anterior dislocation of the humeral head. This obviously results in impaction of the humeral head against the labrum and the anterior aspect of the glenoid as well as the anterior capsule. And when you have this injury, you develop something called a Bankart lesion, which can come in various types, and we shall talk about this. On the other hand, the posterior aspect, and more specifically the posterior superior aspect of the humeral head, impacts against the glenoid and gives us what is called the Hill-Sachs lesion. Along with this, you see injury to the capsule as well, and therefore there are three structures affected in anterior instability: the anterior inferior glenoid, the posterior superior humeral head, and finally the glenolabral capsule. Now on MRI, when we look at the appearance of the anterior inferior labrum in somebody who has had a shoulder dislocation, what we realize is there's a classic Bankart lesion where essentially there is a tear of the anterior inferior labrum. Along with it, there is a break in the anterior periosteum, and so you have a separate piece of anterior labrum that has come off and the periosteum is broken, and this is your classic Bankart lesion. And you can see it here as the triangular black piece of labrum here, and you can see that there is no periosteum connecting it over here, and this is your classic Bankart lesion. If we look towards another alternative that can happen, is you can see that the labrum comes off, the periosteum strips off, but there is no fracture of the periosteum, and so here you can see this labrum here, you can see the tear, and you can see this periosteum lifted off, whereas this black line is the cortex of the glenoid, and this is called a PERTHE'S lesion. And some people like to break the periosteum and then fix this back so that healing is better. The presence of the periosteum being there can lead to a hindrance in healing. The third lesion is that when you have an anterior dislocation, you can have not only the labrum, but along with the labrum, a small portion of the glenoid articular cartilage also coming off, and that is referred to as a glenolabral articular defect. And so here in this case, you can see this is the anterior margin of the glenoid. This is the actual labral tear coming off. This is a small piece of bone in the Bankart, and here you can see this articular cartilage, which is this gray layer back here, and you can see how it's thinned out and there are little flakes or streaks of articular cartilage here, and this is called a GLAD lesion or a glenolabral articular disruption. The next lesion that people commonly talk about is something called the ALPSA lesion or the anterior labral periosteal sleeve avulsion lesion. And here essentially what happens is that the periosteum strips off, but the labrum itself buckles underneath that periosteum. So when this comes back to heal, the labrum sits in between the periosteum and the glenoid, and therefore the labrum does not heal properly in this more anterior location where you would like it to be. The last lesion, while all these lesions are variations of lesions that happen on the glenoid side, you can have something that happens on the humeral side, and here we call this a Hagel lesion or a humeral avulsion of the inferior glenohumeral ligament. So the inferior capsule here, if you will, gets torn at the humeral attachment, and that is called a Hagel lesion. While all this is happening on the glenoid side, the humeral side has a variety of lesions. You can see a flattening type Hill-Sachs lesion. You can see a more wedge-shaped Hill-Sachs lesion, and sometimes you may not really see much deformity, but you see a little bit of bone edema in somebody who's got a known history of dislocation, and this would essentially be the edema, which is the Hill-Sachs equivalent. One needs to be careful when you look in this area because the infraspinatus tendon often attaches here, and you may sometimes see insertional cystic changes which should not be mistaken for something being a Hill-Sachs lesion unless there are other signs. So traditionally in a patient with anterior instability, there has been a tendency to go for a soft tissue repair. So one goes in arthroscopically and fixes that anterior inferior glenoid with some sutures, and this is what you get, which is a Bankart repair. Now What they realized over time after doing Bankart repairs, that there were a bunch of people that failed these Bankart repairs, and they found out that why they failed these Bankart repairs was essentially because with repeated dislocations there was a loss of anterior inferior glenoid bone, and when you have this anterior inferior glenoid bone loss, there just wasn't enough surface area of the glenoid to contain the humeral head, and that soft tissue that was anteriorly in the labrum was tissue with just a soft tissue repair. So they started using various techniques to measure what the estimated glenoid bone loss was, and the simplest way is something called a best fit circle. In this, what they do is they draw a circle that fits best the inferior quadrant, posterior inferior quadrant of the glenoid, and complete that circle to give you a sense of what the total glenoid would look like. My drawing is horrible, as you can see. I don't know how I passed my medical exams. But what you can see over here is you draw this diameter of the circle, you measure this diameter, which is the estimated or the expected diameter, and let's call this AB. All right. So this is the actual distance of the expected glenoid. You subtract from that the missing glenoid bone. So let's call this AC. Okay. And therefore you now get AC, which is the missing bone, divided by AB, which is the actual estimated length of the glenoid, and you multiply that by 100 and you measure what is called the glenoid bone loss. Okay, and the glenoid bone loss, if it is in excess of 20 to 25%, and usually around 22 is where they come down, and there are other variables which we won't discuss in that much detail, but approximately 25% bone loss means that somebody needs to have a bony procedure to fix or to reinforce that anterior inferior glenoid. And the bony procedure of choice is usually where you take the undersurface of the coracoid and you transfer it to fill that gap in something that is called the Latarjet procedure. And there are many modifications of this. One thing for you to remember when you're reading scans is to always look for coracoid fractures, because these may happen in some anterior dislocations, and those coracoid fractures, if that is the case, then you may not use that coracoid for fixation, and they would use an iliac crest graft. So now they found that even after all of this, people still kept dislocating, and there was a further concept where they talked about the engaging Hill-Sachs lesion. For any of you who are married, you realize that engagement is always a bad thing because it's the beginning of the end. No, I'm just kidding. But I think the important thing for you to remember here is that you can have something called a Hill-Sachs lesion that is large, and you have the glenoid, and when the person externally rotates, that Hill-Sachs lesion basically engages or gets locked and trapped within the glenoid, and that is called an engaging Hill-Sachs lesion. And the question was, if you have an engaging Hill-Sachs lesion, what should you do? It usually requires a bony reconstruction, possibly even some surgery towards the humeral side to reinforce the Hill-Sachs lesion. And the question was, before surgery, is there a way that you can predict that something is going to be engaging or not? Because otherwise they would look under arthroscopy to see if something was engaging or not. So they did an interesting study, and they looked at very interesting dynamics of shoulder movement, and they figured out that essentially of the entire surface area of the glenoid, approximately 83% of that glenoid was the part that was articulating with the humeral head. So 83% of the glenoid articulates with the humeral head, and that is called the glenoid track. On the other hand, the width of the Hill-Sachs lesion, the horizontal width in the axial plane, is what is called the humeral track, and you measure that not just by the width of the Hill-Sachs lesion, but you measure it to the distance of the Hill-Sachs lesion to the footprint of the rotator cuff. Now the good news is that usually the width of the Hill-Sachs is the same as that of the distance to the rotator cuff footprint, but sometimes you may have a little bit extra, and that is called the humeral track. So if the glenoid track, which is 83% of whatever the residual glenoid diameter is less than, or if the humeral track is greater than the glenoid track, so the width of the Hill-Sachs lesion is more than the width, than 83% of the width of the glenoid, then you are likely to have an engaging lesion and you are leading to a more aggressive surgical plan. What can they do on the humeral side? What they do is they take a part of the infraspinatus muscle, they clamp it into that Hill-Sachs defect, and they fix that, and that is called a remplissage surgery. So that's the next thing that happens. So in these patients, you may have to do a Bankart repair as well as a remplissage. Now, here is sort of how you can measure the glenoid bone loss. So, here you can see the Hill-Sachs lesion. This you can see is where the footprint of the infraspinatus attaches, and therefore this distance essentially is what is giving you the width of your Hill-Sachs lesion or the humeral track, right? And then on this side, what you see over here is you can see the amount of bone loss here, and that gives you the residual diameter, and this residual diameter, 83% of that is what gives you your glenoid track. So what can happen in patients with instability? You will have 4 different common variations that you can see. One is you see a soft tissue Bankart lesion, and in that case obviously arthroscopic repair is the best thing to do. 2 is you may see somebody with a large Hill-Sachs lesion, that means a large defect on the humeral side but a very small Bankart lesion. So if it's a soft tissue Bankart lesion, you may just repair it arthroscopically, but your primary concern is on the humeral side, and therefore you will do a humeral sided reconstruction for these patients, which would be a remplissage. On the other hand, you may have somebody who has a small Hill-Sachs and a large bony Bankart with bone loss, and in this case the answer would be probably to do a Latarjet procedure. And then finally, when you have patients who have moderate to large Hill-Sachs lesions as well as glenoid bone loss, in those patients you may decide to do both. So in summary, anterior instability is the interplay between glenoid, humeral head and capsule when the humeral head dislocates anteriorly in relation to the glenoid. Soft tissue glenoid lesions, so I will have arthroscopic management. MRI is excellent in helping you to describe, differentiate and identify the extent of these soft tissue lesions, whether you talk about the Bankart, the PERTHE'S, the ALPSA, the GLAD, as well as the Hegel lesion. Bony lesions may require greater interventions. If it is on the glenoid side, then you're looking at doing something like a Latarjet or a congruent arc surgery. And if it is on the humeral side, you're looking at doing something like a remplissage, which is stuffing the infraspinatus into that gap. So today the interest lies within engaging and non-engaging lesions, identifying the aspects of bone loss, which side they are on, and then deciding what the appropriate procedure to help this patient would be. So with that, I'll stop this. Hopefully we've got a good sense of what anterior instability is, what the role of imaging is in management, and meanwhile, to all of you out there, stay safe, keep up the great work, and remember, we're all thinking of you a lot of the time. Thank you.